It's really my pleasure to introduce, I think this will be the third in our series on healthcare reform implementation issues in California. You may recall we had Peter Lee here to kick it off. I think it was back in October on the exchange. We had a presentation from Bruce Bodakin, the president or immediate past president of Blue Shield, and also Larry Levitt from the Kaiser Family Foundation. And this now is in the third in our series to hear about the governor's report released on December 19th, Get Healthy California. And we're really pleased to have with us today our Secretary of Health and Human Services, Diana Dooley. And I'm going to give you a little bit of Diana's background, not all of it. Most importantly, she is serving as our Secretary of Health and Human Services and doing an outstanding job in the judgment of many of us in leading that complex organization at a very challenging time in our state's history. She also is a member of the Benefit Exchange Board that Peter Lee is leading. She also serves on a number of other committees at the state, the Olmstead Advisory Committee, Alzheimer's Disease and Related Disorders Advisory Group, the Child Welfare Council, Managed Care Medical Insurance Board, and the list goes on and includes the Strategic Growth Council as well. Prior to her current position in the Brown administration, she served as the president and CEO of the California Children's Hospital. We have 8 of them here in the state, and they provide about 40% of all the care for children in the state. She actually began her career, though, at the State Personnel Board a number of years ago and served on the staff of Governor Jerry Brown during his first term at that point in time. She received her law degree in 1995, actually was in the private sector running a public relations and advertising agency, was in private practice of law as well, before becoming the general counsel and vice president at Children's Hospital, Central California in Fresno. And from that, again, to the CEO of the children's organization in the state. She's very active in a number of community organizations, including being past president of Planned Parenthood, the Visalia Chamber of Commerce, and the Central California Futures Institute. I've had a real pleasure of working with Diana over the last probably 6 or 7 months in 2 capacities. One, she was a key member of our Berkeley Forum, our own report that came out, I think, on February 26th, on creating a new vision for California, mostly from the private sector. Diana was a very reasoned voice in those discussions and clearly contributed to the quality and insight of that report. But also in the last 6 months, a very quick time frame when the governor announced the Get Healthy California, Diana and Pat Powers led that initiative, and I had the privilege of serving as one of the advisory task force to that initiative. So what she's going to talk about today is Get Healthy California, how we're going to make the aspirational goal, which is to make California the healthiest state in the nation by the end of the decade and at an affordable cost as well. So Diana, it's terrific having you here. She's going to talk for maybe a half hour, entertain about 15 minutes or so of Q&A. She has an emergency meeting she needs to get to in the city, so she does need to leave around 5 or shortly thereafter, but we can field some of the questions if you still have questions at that point in time. Diana, welcome.
Thank you. Thank you very much, Steve. It is my pleasure to be with you, and I apologize about the timing. I always try to do more than will fit in. I say, thank goodness there are only 24 hours in a day, because we just all fill them up, and I know you're very busy people as well. I do, as Steve said, want to talk a little bit about how we are trying to do it all in California. The Affordable Care Act is a very ambitious undertaking, as you have understood and all that has been written about it. It is the very most ambitious thing that this country has done in the way of healthcare. They say often since 1965 with Medicare and Medicaid, but I really think it's even actually a much bigger lift than that, because when you start something from nothing, it's a lot easier than changing something that has 40 years behind it. We have built a system. I loosely call it a system. There really isn't a system to healthcare, I would suggest, in this country. But Rube Goldberg himself would not have built a system that looks like this. It has been pulled together. I'm an old farm kid, so we used a lot of chewing gum and baling wire on the ranch, and that's what this feels like. We keep solving problems a little bit here and a little bit there, and we're certainly seeing that as we're trying to move in a comprehensive way to make the promise of Obamacare real in California. But we have a lot of programs that have been adopted and that we administer in one-off kinds of ways to meet particular needs, whether it's from family planning or HIV/AIDS or mental health or substance use disorder. All of these things we have thrown a little bit here and there, and we have a very, very complicated organism that we are trying to make sense of. Don Berwick, who is a long leader in the field of public health generally and quality improvement, specifically with the Institute for Health Innovation, and was Obama's first director of the Centers for Medicare and Medicaid, partnered with me last spring with this 6-month effort to frame a blueprint that we called Let's Get Healthy California. And we did it around his theme that he articulated so clearly of what he calls the triple aim: better care, better health, lower cost. And so we took those principles of looking for ways that we could improve the healthcare delivery, give people better value, and improve population health. It was very ambitious. We set out to do it in 2 parts. What you measure matters. I'm convinced. I've worked for many years in healthcare to try to find quality metrics. I've been working with the Institute of Medicine on just coming up with some core metrics around that triple aim of better health, better care, and lower cost. It's very hard to do. I often say measuring quality in healthcare is sort of like the Supreme Court in pornography. You know it when you see it. It's very difficult to come up with metrics that are well appreciated, and I spent a long time with the hospital industry in the last decade around a project to come up with uniform standards that the health plans would agree to use, and we spent many thousands of hours and thousands of dollars to come up with a plan that was finally accepted, and at the end the plans still all used their own metrics, and so it's not very well used. So setting the quality measurement aside, we decided that what we needed to do to determine whether we could be the healthiest state in the country, we had to decide what that would look like. And to decide what that would look like, we had to decide what would we measure. So we spent 3 months looking at what we already measure. One of our goals here was to come up with something that wasn't starting over anywhere. And so I thought, from my 15 years in healthcare, which is a relatively short amount of time, that there were probably scores of measures that already existed. I didn't understand that there were hundreds of measures that already existed. And so we set out a framework of themes that we wanted. So we began to define what the triple aim would look like in California, what some metrics were that already existed, and what we should set as our targets. So that took us from June to September. And then from September to December, we collected examples of innovations that are already happening. Our goal was to not start something new. Everybody has an overlay of a lot of hard work to do to implement the Obamacare here. But we came up with 39 measures in 6 categories. The report is available at the agency website if you want to see the full report. Our agency website is CHHS, California Health and Human Services, .ca.gov. So the website is chhs.ca.gov, and there's a tab at the top that says Let's Get Healthy. Those indicators that we adopted fall into 6 categories. We have what we call health across the lifespan, which are healthy beginnings, living well, and dying well, and I'll come back to those three categories. And then the pathways to those goals would be creating healthy communities, which deals with population health, lowering the cost of care, which deals with finance, and redesigning the health system on health delivery. And there are a lot of initiatives going on in all of these areas, but we tried to bring it to something that we could really point to and work on and bring some order to the many, many activities that are going on. In Healthy Beginnings, clearly we're talking about early life and early health and prenatal health and infant mortality and maternal health, but we're also talking about school readiness and reading and some of the indicators that, one of the things I wanted to say, because I started talking about disparities, but across all of this, of all six of these frames, we have health equity, and we have incorporated eliminating disparities in health through all of these six categories. Living well, we were dealing with preventing and managing chronic conditions, identifying ways that we can do that better through integrated and coordinated care, but also patient responsibility and engaging patients in their own care. And dying well, we recognized, is not an aging issue. Living well is at any age, and dying well as it is at any age. Certainly in my experience with children's health, and the children's hospitals deal with most seriously ill and injured. So we were dealing with death at 6 weeks and 6 months and 6 years. So dealing with the dignity and choices and the compassion that goes around the importance of how we live, but also how we die. And we thought that that was an important conversation to have in terms of being the healthiest state in the country. The three categories of population health, the cost and delivery and financing, the cost of financing and how we deliver care relate to all of those other categories. And so I'm not going to go through the 39 indicators and the work that we're doing, but we have created 6 work groups that are now carrying on the ways that we can use the website and public appearances and illustrate to Californians how they can be engaged in making California the healthiest state in the nation. We received a grant in the course of this. We applied for a grant for the Centers for Innovation at the federal CMS, Centers for Medicaid and Medicare, and were granted that grant, that award, to design a system of finance reform. Much of the conversation around the Affordable Care Act has been around reforming the system, and there are lots of words that are used. We have health, home health, health homes, medical homes. I just talked with Leslie here about Healthy at Home for mental health service delivery. There are accountable care organizations. There's the Coordinated Care Initiative. There are bundled payments, there's reference pricing. There are a lot of words that the people who use them know what they're talking about, and the general public doesn't really get what we're talking about. We have, and I said this on day one in this job, and I understand it from my experience, that central to the Affordable Care Act is a recognition that we have to move away from a unit pricing system. A fee-for-service system values volume. We have to move away from volume and into value. To really value, we've got to have quality measures or outcome measures. We've got to set targets. And we've got to move to a system of some kind of different pricing structure besides piecework. We can't pay for every visit and every test and every procedure and every device and every drug. We have to find some way of collectively being interested in health instead of interested in illness. The system that has built up over the 40 years of payment, and I worked for Governor Brown the first time, and by 1975, 10 years after Medicare and Medicaid were first enacted, we were already then in the second generation of cost control. Because when it started in 1966, people just sent their bills in and everybody paid cost, and the government was upside down, the second year out of the box, and started looking at ways. We had certificate of need. Some of you may remember when we thought we could control cost by controlling construction. And so we set up health systems agencies all over California, and we tried to decide whether a hospital needed to have 50 more beds or whether a clinic needed a CAT scan, a piece of equipment. That lasted about 10 years. We went in 1983 to a system of contracting for hospitals trying to control cost. And then, of course, in the 90s, we went to managed care. Managed care had a lot of problems early on. It was completely dominated by the plans and started very quickly to get a sense that it was insurance companies taking our money and not providing care. And so at the outset of this conversation that began with Obamacare in 2010, really in California it had started much before that, recognizing the need to reform the system, was the recognition that we've got to talk about coordinating care from a patient standpoint and not from a payer standpoint. And one of the big hurdles is getting over the perception that people have of HMOs, health maintenance organizations. And it's sort of like a lot of things that we see with people criticizing government. Government isn't the solution, it's the problem. But except when it came to the conversation around Medicare, and then it was keep the government out of my Medicare, with no appreciation that something they really like is actually government. And I think that's the same way we have a little bit with HMOs. People like Kaiser, and Kaiser is held up to be the gold standard of integrated, coordinated care in a capitated system. And yet people don't think of that as an HMO, and that it is the mother of all HMOs is Kaiser. So we have to move the thinking that nobody can really navigate this complex health system by themselves. We all need some kind of manager or coordinator or someone who is helping us get to the right person at the right time with the right level of care. But there's a lot of apprehension about managed care, but it is at the core of the theme of Obamacare that we can't pay for every single unit as a unit cost, and we've got to put somebody at risk for being interested in health instead of illness. That can't just be the payer, and it can't just be the physician. It has to be a coordinated program of care that we are trying to do. So we're looking at all the different labels and names that people use, but recognizing that coordinated care is at the heart of it. We're doing that with a demonstration. The Affordable Care Act allowed states to apply to have a demonstration of coordinating the care of what we call dual eligibles, people who are eligible for both Medicare and Medicaid. Medicaid is the national term, Medi-Cal is the California term, and they are completely different products and programs. And so you can be eligible, while Medicare is primarily a seniors program, it isn't exclusively a seniors program. People with supplemental security income and disabilities are eligible for Medicare at many ages. And so what the dual eligibles, those that are eligible for both, are those with chronic conditions or disabilities or people who are high users of healthcare because of their position in life. But the medical part of it is paid for by Medicare with no understanding of what wraparound services or support services or long-term care services are needed. And Medi-Cal pays for those long-term support without having any engagement or involvement or coordination of the medical services. So it's long been understood that if we could coordinate that care for that population, they call it 550 or 80-20, whatever it is, the numbers that you use, 50% of the cost is spent on 5% of the population, or 20% of the population uses 80% of the cost. It's still, the proportionality is there that we spend a very high percentage of our investment in healthcare on a very limited population. And as an insurance product, That's what the insurance companies have been so good at. That is another change of under Obamacare, that you can't just look for healthy people and sell them insurance and exclude people who need services. So the whole issue of no pre-existing conditions, or what's called guaranteed issue in the insurance industry, is the recognition that you've got to level this so that we're not asking the government to pay the highest cost, and that we're spreading that cost over the whole population. But the problem with that is that the people who are healthy, who are buying really not, we call them the skinny plans, but plans that don't have very much coverage because they're healthy and they don't think they need it, are now going to have to buy a more comprehensive plan because we're providing comprehensive benefits to everybody. So there's going to be a really hard transition next year as we start moving into the implementation of Obamacare. But over time, it should level out. And the idea is that if you have universal coverage, you're not going to have some people falling out of the system and falling into the Medi-Cal program that pays after you've lost everything and you have no income, you have no assets to support you. Then the government comes in and takes care of that. So it's leveling this out and getting to a point where we can have coordinated care, people can get the care they need when they need it, is the ideal. It's going to be a heavy lift to get there, and there are going to be a lot of complications with that. And so what we're trying to do in California is do as much of this as we can from the outset. There's no state in the nation that has embraced Obamacare to the degree that California has. But it isn't going, there are going to be some rocky places. We are going to have some capacity problems with putting upwards of 1 million people into a system with an expectation that they're going to be able to get to a provider. The payment rates are the lowest for the Medi-Cal in the country, in large part because we've been so efficient, because we have gone to managed care faster than any other state, because we have controlled the cost of hospitalization better than any other state. But it's sort of like the limbo bar. You know, how low can you go? We really can't go any lower and get under this bar of adequate care. I will say, however, that even though we have the lowest cost per beneficiary of any state in the nation in our Medicaid program, we have consistently at or above average outcomes. And some of our outcomes are extraordinary, like infant mortality, where we're a leader in the country. So what you pay isn't necessarily what you get. And that's what we have to maximize. We have to find where are those efficiencies that are really working for the benefit of the patients and the value of this program quickly enough that we don't run into problems both with capacity and with cost of care. There are a lot of concerns that people have, but I do believe in Don Berwick's goal and President Obama's goal that we can improve health, make the care better, and lower the cost, but it's going to take a lot of cooperation from a lot of people. And as we often see in a time of very dramatic change, people get into a hoarding mentality, and people want to hold on to what they already have because they're afraid of the future and they don't know what's going to change and when it's going to change and how it's going to affect them. So there are a lot of worried participants looking forward to making this work in California. But we're moving on a lot of fronts and we're moving very, very quickly. I'm just thinking of all the things that I could tell you that we're doing, some of which you know, some of which you don't. But one of the things that occurred to me about, I think always of where's it going to go wrong and when is it going to go wrong and how am I going to fix it fast enough? That's sort of my 3 o'clock in the morning visions. And one of them is IT. We're building a completely new IT infrastructure to support a new enrollment and eligibility program. The Affordable Care Act will make it easier for people to enroll in Medi-Cal, and it will make it easier for them to stay in Medi-Cal than currently exists with the current rules. we're putting two completely different products side by side. Medi-Cal is a health delivery government-sponsored program that doesn't operate anything like an insurance plan. You don't enroll in Medi-Cal when you're healthy, the way you do in an insurance product. When you're sick, if you're eligible, you get on Medi-Cal. And so the eligibility is retroactive. So a lot of the eligibility in Medi-Cal comes from a provider. Somebody presents at an emergency room or in a clinic or at a doctor's office. They get their information, they find out they're eligible for Medi-Cal, they go ahead and provide the service, and then they apply for Medi-Cal, and Medi-Cal goes back to the point of service. So enrolling isn't that critical from a timing standpoint in Medi-Cal. Insurance, on the other hand, is based on indemnification, so you have to have a balance of healthy people and sick people, just like in homeowners. Everybody doesn't expect their house to burn down. Everybody doesn't expect to get in a car accident to use their insurance, but they buy insurance. Most of us buy homeowners and auto insurance hoping never to use it. People don't buy health insurance hoping never to use it. They buy health insurance and they expect to use it. And some people wait until they need it to try to buy it, and then it's very expensive. Obamacare is going to change all that and level out those prices so that healthy people are going to pay more than they pay now, and sick people are going to pay less than they pay now. But it's going to be available to everybody. So it's very important at the outset to get as many healthy people in the pool as possible. So we've got to market to get people to enroll and to buy the health insurance. But when we do that, we're going to get a lot of people into Medi-Cal who are healthy, that we already have a fixed price to pay for them that is based on sick people, not on healthy people. That's maybe a little too in the weeds for you, but it is a huge issue for me to deal with in estimating the cost of the Medi-Cal expansion when we're going to design one system that is going to enroll in both by the same people, so that when you go to the website, or you go to a certified application assister in your church basement, or you go to a clinic, they're going to go through a test, and you're going to be told, yes, you're eligible for Medi-Cal, or you have an insurance product and you can buy it, and depending on your income, we're going to give you a subsidy, and we're going to calculate that subsidy. And by the way, we're going to have to train 25,000 people in all these details by July. Welcome to my world. It's very complicated. It's going to be hard to do, but we are very committed to doing it and doing as much of it as possible, as quickly as possible. And that leads to the front pages of the stories that are very timely right now in terms of how we are going to do the Medicaid expansion in our partnership with the counties. And a lot of pressure to expand even further. I got a question before we started here about undocumented. The people who are undocumented, we have several million in California. I always say I'm a social scientist. I don't do numbers, and so I don't really remember the numbers, but I think it's in the tune of like 2 or 3 million. Well, there's 7 million uninsured, but the number who are undocs are not quite half, I think, of the people who are uninsured. But they are not only not included in Obamacare, they're expressly excluded from even buying insurance with their own money on the exchange. So it is a serious problem, how we will continue to provide care for that population. But I have to set that problem aside in order to get the basic part of Obamacare up and going, and I hope that they will address that when they deal with immigration reform, which they say they are going to do in Washington. But that was a federal decision, that wasn't ours, and we've got to deal with what we have to do at the county level and at the state level with being prepared to accept this funding that the federal government is offering in January for the populations that are eligible under the Act. So there are a lot of places where there is strong advocacy for us to do more faster. For example, we have 13 approved languages in California for Medi-Cal, and we are working to make all those languages available in the exchange and with Medi-Cal from the start. But there are hundreds of languages. I mean, when I was at Children's Hospital, we had 106 languages that we used telephone. A lot of people want us to have live people. We can't have live people in that many languages. languages. We're going to do it for 13 languages. No other state, even the federal government with their federal exchanges, they're doing 2 languages, English and Spanish, and maybe not Spanish in some places. So as frustrated as groups get in California that we're not doing everything, we're doing so much more than anybody else is. And I am committed to doing as much as we possibly can, but we have to do it in a sustainable and responsible way that we're not either overreaching and trying to do more than we can reasonably do within the time that we have, or having it not be sustainable, so that we go out too far too fast, and we've got to pull back. Governor Brown is notoriously cheap. I worked for him in the 70s, and I'm telling you, he can't rub 2 nickels together. Frugality, in fact, I was joking, we now have a Jerry Brown Pope. Everything about Pope Francis is Jerry's aesthetic Jesuit training. It comes through in everything he does, but he is bound and determined not to go backwards on the 2 years that he's invested in getting this budget balanced. And so he is immensely worried that we'll get caught in the federal deficit issues, or that we'll have problems sustaining what we start. So there's some tension around that, and there are certainly advocates that want us to go a lot further than we feel comfortable to go, but we are all moving in the same direction, and we are doing a lot of very good work, and we're making life better for millions of Californians by implementing Obamacare. So with that, Steve, I hope I've been provocative enough to get some questions and foster some conversation with you. And I regret that I'll have to leave in about 20 minutes. But I do have a couple of people here, Jim Sunan from my staff and Valerie Mitchell from our office, who can stay and engage and either answer or record questions to bring back to me if you have the appetite to stay longer than I can with you.
Great. Thank you, Diana, very much. We're going to open it up for questions. We have a couple of mics. We'll hand the mics to you because this is being recorded for posterity's sake as well. So questions while people are ready. Okay, over there. Start over there, right there.
Hi, my name is Vanessa, and I'm a patient navigator at the Petaluma Health Center. We're an FQHC, and so I help people connect with insurance, and they've been asking a lot of questions about the exchange and things like that. And so we're wondering, since CMSP in the area, the county medical insurance program, already covers the population that's going to be eligible under Medicaid expansion, how is that transition going to work for them? If they're already covered by CMSP, how are they going to get into Medi-Cal? And also, we've had a lot of experiences in the difficulty from the Healthy Families transition over to Medi-Cal. What lessons have been learned from that, and how are you going to use that in the CMSP transition?
Good questions. And the California, under the Schwarzenegger administration, worked with the Obama administration at the very beginning after Obamacare was enacted and created what they call a bridge to reform, which was a waiver process with the federal government that brought in $10 billion over 5 years to reform the county delivery systems. And a part of that was to create what are called low-income health programs. And these low-income health programs are the way in which people who are not under the current rules eligible for Medi-Cal are getting a Medi-Cal-like program, with the anticipation that those people will transition after January 1 either into Medi-Cal or to the exchange, whatever they're eligible for. There's a lot of variation in the counties of how they have operated these low-income health programs. We are currently evaluating how to do the full Medicaid expansion in January with the funding from the federal government to either expand and make uniform the low-income health programs, or take the expansion population and add it to the Medi-Cal population. Most of the counties prefer the the integration of the low-income health program into the state Medicaid program. There are advocates that want to maintain the low-income health program for like the NDOCs and for others. All of that is being worked on right now on how the best way to do that is. But our intention is to have that resolved by the fall so that it will be a pretty seamless transition. but no transitions are really seamless. The move of Healthy Families children into the Medi-Cal program is again a way to eliminate all the different kinds of programs so that ultimately we'll have Medi-Cal and purchased insurance. But Healthy Families is just one distinction. We've got many state-only programs that we are not going to transition at the outset, but that over time we want to simplify and get so that people can understand, and we don't have to have armies of people to understand all the different programs that people are eligible for. It's a big lift to get there, but we are pushing as hard as we can. And with regard to being able to answer the questions that people come to you, they come to us as well. We are working backwards from the open enrollment period that will be in the fall to transition people into one product or another. But it's sort of like getting everybody ready for the dance and not starting the music. You know, we can't really start the massive public information campaign until people can actually pick up the phone or go to a website and do something. You know, if we had it all out there now, they'd be calling the 800 numbers, and we've got people answering 800 numbers now, but they can't do anything until the end of the year. So working backwards from that, we're designing the training programs now. So we'll be training the trainers, we're building the IT system, we'll work with all the existing application assisters and navigators that exist under the current system and make the transition to the rules that are required under the Obamacare, and over the summer we'll be starting that public education. We have a massive budget that the federal government is paying all the costs of the exchange, which is now called Covered California, that will do the marketing and outreach to answer some of these questions and we're doing a lot of focus groups and working to be ready to go. So the Healthy Families transition will be completed by the fall, and again, that is to keep the first part of that transition. Almost 100% of the kids have stayed with the same plans, and over 99% have stayed with the same providers. We planned it that way so that those that could stay in the same place would stay in the same place, and we're looking to have that coordinate with the exchange products or the Covered California products to have as much consistency with plan and provider as possible. The plans are out negotiating on their networks now because we're in the negotiating process for what they're going to sell on Covered California. So there's a lot going on. I know there are a lot of questions, and it's very frustrating for frontline people not to be able to get the answers. But we're getting the answers as quickly as we can, and we'll be providing them once there's something people can actually do with the information. Yes, ma'am.
Thank you for your talk, Linda Newhouser from the faculty here. Very thorough and easy to understand, a very hard topic. You mentioned the problem of big words and how hard it is for the general public to understand this. And I wondered what the plans are to help people like the assisters and other people try to get information at a level they can understand. So one of the things we've done here at the school is to do a study of the materials that are available right now. We found them, you know, close to a college reading level, and the average person reads around the 8th grade. So what are the plans to take that kind of information or to create new information that would be easier for people to understand?
We're working on that very issue. We have contracts and subcontracts with marketing and public information groups. We're testing it in focus groups. We're working with community groups and ethnic groups. We have grants that will be going to community educators throughout California, and we're addressing it we're aware of the issue, and we are addressing it in every way we can. Some of the information that has been difficult in the past is in part because it comes to us with a lot of requirements. CMS is, with all due respect, sort of a micromanager. And so there are a lot of regulations that come to us that we're still working with them now to try to manage. And so they have sort of 30,000-foot idea of what should work on the ground, and it doesn't always translate. And I will admit that even the relationship between the state Medi-Cal program and the county programs is hard. And the county programs, each of them has their own idea. You know, words are only as good as the people who are using them. And it's this area particular, and I have always been, when I started many, many years ago in state service, I refused to use acronyms. And everything about state service is acronyms, EDD and SPB and CDCR and HHS. And I refuse it. I use words. It's what I said when my kids were little, use words, Megan. So that's what I do every day. And everybody laughs at me because it's sort of become a thing. Use words. Diana wants words. But it is related to that sense of speaking in a way that people can understand and respond. And so it's a very high priority to me. And I'm doing everything I can as chair of the Board of Covered California and as the agency secretary over Medi-Cal to make it. We just hired, I'm revamping the Office of Patient Advocate, and the goal of that office now is to be the patient within government, not to be another clearinghouse or another 800 number, but to be some group that is trying to read it as though they were a patient, to try to look at the benefits. When we lay out our matrix at the exchange about trying to compare apples to apples, that we want that to be read as someone with a 6th grade or an 8th grade education. So it's a goal. We may not be there, but wanting to be in the right place, I think, is a good first step. Thank you. Seth.
Yes. I wanted to follow up on the question about undocumented people. It sounds like one of the main problems with figuring out how to provide healthcare is that the federal system has expressly excluded this group of people from funding. And I was thinking about other times that that's happened and what California has done, and I was thinking specifically about stem cells, when the federal government said none of our research money can go to stem cell research, and California said, okay, we think this is a resource we have, all the scientists we have in the UC system and Stanford and everything, and we want to take advantage of that, so we're going to create our own system. And I'm wondering if we, as California, should recognize the undocumented people who live in our midst as a resource who we want to support in some way, and what possibilities there might be in the future for that.
I think in the future, frankly, I don't have any more bandwidth right now. But let me tell you a few things. There are certain services. There's emergency Medi-Cal under certain circumstances, and the counties, through their indigent care obligation, provide a significant amount of resource now to people when they present. It's not ideal, it's not preventive, and it's not population health, but it is something through the requirements to treat all those who present in emergency rooms, for example. It's why so much care is delivered in emergency rooms, and we haven't recognized that. But I think we fundamentally have to change the conversation from cost shifting of how we're paying for things by shifting costs to what the basic unit cost of healthcare in this country. It is a crime to me that we have the quality that we have for the cost that we provide when you compare to any other industrialized nation in the world. Nobody spends what we spend and gets as little back for it. We have very good care in this country, but we pay a lot for it, and we have to have the conversation about unit cost of delivery. I mean, it's hard to do right now when we're trying to do everything else, but the effort to address this issue may be something that California will pick up, but they aren't completely without care now, and part of the tension in our proposal for Medicaid expansion is the recognition that the state of California has about $1.5 billion each year that it spends on health care that the counties provide. Much of that obligation of the counties will be relieved with 100% funding for those people who will be eligible for Medi-Cal. We can't pay for that twice. And so the tension that's going on right now about how we expand is actually a negotiation between the state and the counties over the allocation of risk and funding. And many counties are arguing, well, we have all these undocumented that will still need care. Let's leave that state money in the counties and let them use it for the undocs. Well, that would be fine if we didn't have unmet needs for that money too. People want to add back adult dental. They want to provide funding for mental health. There are any number of unmet needs, and we should have an honest conversation and not just say because the state has been providing that funding to the counties that the counties should have the right to use it any way they want to. So that is a hard conversation, but it's an honest conversation, and it's the one we're having in Sacramento right now with our county partners. Yes, Leslie.
Yes,
Right.
Leslie Reed. I'm working with Mental Health America at California on developing health homes for individuals with serious mental illnesses, as we spoke about earlier. And given the possibility of extra bandwidth to create health homes here in California, in combination with the California Endowment's pledge to pay the 10% state match for these, I'm wondering where health homes might come in on that enormous list of considerations of projects you're working on.
It is a priority, but it isn't at the top of the list right now. There are so many good things that we should do, and our primary issue right now is getting the lift on the Medi-Cal expansion and the Coordinated Care Initiative broadly to make that happen. We're changing the way we're paying hospitals in July. We are making the transition of healthy families to Medi-Cal. We made the transition of seniors and persons with disabilities last year. We have got a lot of foundational steps, and I've been interested. I've talked to Bob Ross. I've looked at what the California Endowment wants to do, and it's frustrating for them to see that there is an opportunity for a 90-10 share, but we have to get the foundation laid, and we don't have that in place yet to start building on that. But it is something that I'm interested in, and we will get to as soon as we can. Yes, ma'am.
Hi, I'm Margareta Brandt from the Health Improvement Partnership of Santa Cruz County. And I was wondering if the state's doing anything to address primary care capacity and workforce development.
We're identifying and recognizing as everybody reports, and that the lead time on training physicians is very long. There have been a number of steps that have been taken. I think there is no question that we're going to have capacity challenges when we get to this, and a lot of the response is just to pay more. We can't just pay more for the same kind of people and the same kind of care. We are going to have some really honest conversations about the right level of care. And part of our coordinated care initiative, for example, is a part of that conversation where we think with more support in long-term support and home care, for example, we can keep people out of institutional care, and we can train home workers to help people stay in their home and avoid care at a higher level. We don't even need any scope of practice conversation to do that, because home care workers and companion care right now does that, and we want to do more of that. But there is a broad range of health and parahealth professionals that could do more than they do, and we've got to have that conversation, and I think that will come when we can't get everything done in the way that we have delivered care in the past. But again, it's something that I recognize. I've got some other things that I've got to do first. Although the conversation is starting, Senator Hernandez, the chair of the Senate Health Committee, had a press conference last week really talking about the need to have scope of practice conversations, and I think that will continue. We will do more training. We need more training. I met this morning with the UC Riverside, that are people who are trying to get their medical school lifted. There are a lot of needs that people have, but at some point we're going to have to circle back to who does what, when, and where, and reconsider some of our concepts of what you have to see each different kind of professional for, and how we can expand the notion of that, for physicians included, in that conversation.
We want to be respectful of your time.
Go ahead. Thank you. Perfect. Thanks.
I'm
Thanks.
Jeff Oxendine. I'm Associate Dean of Public Health Practice. I've been working with the State Health Workforce Development
Great.
Council. And so I just wanted to tag on to what you just mentioned. And I agree that you have other key foundational things to get in place. And just wanted to know that we have a Health Workforce Development Council plan that's been taking 2 years to put together about health workforce. And we'd just like to see how we can align our efforts with you.
Great.
better.
Bob David is the director of the
Right.
Department of State Health Planning and Development, OSHPD commonly called, but it is a workforce and workforce pilots. In fact, we just finished a very successful workforce pilot with UCSF and got some legislative authority to continue it until we can actually get it over nurse midwives and nurse practitioners providing early term abortions, which was very difficult and very sensitive, but very successful. And we have finally got a little bit of legislative light on that. So we'll continue to look at those kinds of pilots.
Great.
Yes,
Thank you.
ma'am.
I'm Susan Ivey. I'm on the School of Public Health faculty. I just wanted to check, it sounds so efficient when you describe these sort of two that you're aiming for systems of care where you'll have private insurance and Medi-Cal. But there's all these other sort of niche programs at the state level and things like maternity-only care. You have FPAC that's really for family planning, and frankly, workers' comp, which is a whole other
That's
system.
a whole nother subject.
Just wondering,
Yeah.
auto insurance, just
Yeah.
wondering, is the conversation going on about
Yes.
how you can streamline further?
Absolutely. The Labor Secretary is Marty Morgenstern, and he and I worked together in the first Brown administration, and we talk. In fact, he's going to be at the meeting I'm going to right now in San Francisco. Gosh, I don't even know where to start on how important it is to look at workers' comp. It's a complete separate delivery system that makes no sense as it fits into the rest of the delivery system. But it's very, very important and on our radar. Certainly we'd like to address some of that. And, part of the worry that there were a lot of advocates of single payer, and Obamacare is not single payer. Obamacare is built on a capitalist economic chassis that already exists. Everybody's making money. And so it's really popular to point fingers at the insurance company and say they're greedy, but there aren't any not-for-profit physician groups, and the not-for-profit hospitals don't operate any differently than the for-profit hospitals, and the pharmacies and the device makers and the home health workers. Everybody makes a lot of money. I worked at a children's hospital, and in every single community, the people in healthcare make more than their neighbors, and it is an economic engine everywhere you go. So while we talk about wanting to reduce the cost of healthcare, it is a huge, in fact, I would recommend to you, if you didn't see Steve Brill's cover story on Time magazine a couple of weeks ago, but he said the amount that the medical industrial complex spends on political advocacy is 4 or 5 times what the military industrial complex spends. So it is business. And part of that is that economic environment that healthcare is worried that Obamacare is a slow path to single payer instead of a fast path to single payer. And I don't know that we'll ever get to single payer, but we are going to get very quickly to single purchaser. We're only going to have a few purchasers in this system. But even with the power of Medi-Cal and the power of the public employee retirement systems, it's like negotiating with OPEC. And I used to be on the other side of that OPEC table. I was a hospital, and people needed kids' care, and they paid a lot for it, even though we were a 70% Medi-Cal provider. So there is a lot of money in healthcare. Everybody talks about, and Don Berwick, my dear friend, says 30% of it is either inefficient or worse, harmful, that a lot of healthcare provided isn't necessary and isn't needed. But not one single person has ever come in my office and reached in their own pocket and said, here's my 10 cents. I am inefficient to this degree and I will offer it up. Everybody gives me a suggestion for how someone else could be more efficient. And nobody is. So we've got a lot of really hard work to do. And it's going to be painful, and we've got to have conversations with patients because patients think they need everything the system tells them they need. And I'll give you just a quick vignette, and thank you for watching out for my time. But the report came out 3 or 4 years or 5 years ago. All these experts said that women I won't even tell you what my categories is, but I don't need an annual mammogram. I read it all down. I don't need an annual mammogram. I was just shaking for the 2 years I spent waiting for that 2 years to go get a mammogram, because I was so, it was in my mind I had to have an annual mammogram, even though I was in every category of someone who didn't need it. But the American Cancer Society and the pink ribbons and everybody said, same thing with colonoscopy, same thing. I could go down a list of procedures that we've been convinced that we need, that are expensive, and that if our doctor tells us we don't need them, we want a different doctor. If our plan, if our insurance company tells us, we go to the insurance commissioner or DMHC and complain about discriminatory practice if someone tells us we don't need what we think we need. So everybody walks in with their WebMD printout from the computer, and they tell their doctor what they've got, what they need, how many tests they want, which purple pill they need. And so it's very difficult to get at the cost question. But we're trying, and with your help, we will make some progress. Thank you all very much.